My name is Ashok Mala. I'm a professor of psychiatry at McGill, and Jay is one of my colleagues that I'm very proud to say that I was able to recruit him a couple of years ago, 3 years ago from Yale, and the symposium was actually organized by him. And we have several participants in this symposium. However, one of our participants, Jane Scott, is not able to be here for family emergency reasons, and hopefully Ian might be able to summarize some of her work. This morning, I think Pat, in a way, set the stage for a number of the symposia that we will engage in this conference. And one of them, obviously, is this particular symposium in terms of looking at high-risk states and staging models and this whole expanding field of early intervention, and also how, as you will see in the components of the symposium, how we really have to sort of start thinking not only sort of, so to speak, backwards in terms of time, but also forwards in terms of expanding our horizon beyond narrow categories, relatively narrow categories of DSM diagnosis. So without further ado, I'm going to ask Mary Cannon to do her presentation first. That was supposed to be second. And then when Ian does his presentation, is that okay, Ian? That he'll summarize what Jan was likely to say. And in between, I'll do my presentation and Jay's presentation. Mary?
Right. How do I get it started?
I just have about 15 minutes, but you can take a bit longer.
Oh, okay.
15.
Yeah.
And then we'll have enough time for this.
Grand, yeah. Great. Yeah, hello everybody. Mary Cannon's my name, and I am from the Royal College of Surgeons in Dublin, in Ireland, which is medical school. I'm not actually a surgeon. So I was asked. Sorry, I'm a little disorientated because I just flew in this morning, so I'm glad I have a little bit more time so I can get my thoughts together. But I was asked to, Jay, is it Jay or Jay? Jay, yeah, I know. It's funny when you get Jay into your head, you know. But anyway, Jay. So Jay came to see us in Dublin, and I think he was attending a wedding or something. And he gave a very nice talk about his ideas about clinical staging. And I think following on from that, then we had a discussion about the idea of psychotic symptoms among young people, which is a great interest of mine. And so he wanted me to talk about how the idea of psychotic experiences in young people, how that might fit into a clinical staging type model. And we had an interesting paper. There's Ian Kelleher who works with me. He's a very clever postdoc. Now he's a lecturer, and Ian unfortunately can't be here today because he would. It's his paper really I'm basing this on, which was looking at the prevalence of prodromal risk syndromes in the general population, because there's very little information on that. And I mean, as you all know, the prodrome concept was devised primarily by Alison Young and Pat McGorry, who are here in the audience. But it's applied very much to a help-seeking population, and there's very little known about what the prevalence of these syndromes may be in the general population. And I suppose this came to the fore very much a couple of years ago when there was a proposal to add in a risk into the DSM-5, a category for this risk syndrome. So, and there was a lot of debate and a certain amount of panic as to, you know, do we know what we're letting ourselves in for? So, and there's very little. So our study, even though it's quite small, was one of the few that actually looked at the prevalence of these syndromes among a non-help seeking population. Okay, so I'd like to start with the acknowledgement. So I really must acknowledge Ian, who's been a great driver behind this research, but unfortunately couldn't come to the conference this year, and a lot of other people have been involved as well. So I suppose what we're doing, I know Pat gave a talk this morning. Unfortunately, I missed it, but I hope he set the scene for the clinical staging idea. But also Tom Insel from the NIMH has also been saying we should be moving in the direction of prevention. And I suppose that's where our field is slowly moving to, in terms of, you know, is there a pointy thing on this? Yeah, there is. So he thinks we should be moving towards, from our current diagnosis by late symptoms up towards strategic prevention and cure therapeutics. And I suppose that's where we all need to be positioning ourselves, possibly. But there are some caveats to that. Now, I suppose I'm speaking to the converted here in that we now know that psychotic disorders are not just something that psychotic symptoms aren't something that just a few people have who have psychotic disorders, and all the rest of us never have them. So we're now moving to the idea of psychosis as a continuum. Now, it's not a continuum like a blood pressure. There isn't like a normal amount of psychotic symptoms and then a low amount and a high amount. There's actually it's kind of a half normal distribution. So in fact, most people will have none, but there's a significant minority of people who do experience these symptoms without having a disorder. And they've become of increasing interest over the last decade or so. And I've always been very interested in the idea of these, particularly interested in these symptoms among children. Now, Jim Van Os was the first to publish and his group a meta-analysis showing that about 5% of the general population do experience psychotic symptoms. Now, that included adults. And I suppose my feeling is that in terms of risk for psychosis, adults aren't that interesting. What we need to look at are these symptoms in adolescence, because as we all know, the psychosis has its onset in late adolescence and early 20s. So among those who are likely to develop psychosis, we should be looking at the adolescent age group. And interestingly, you can see here, and this pattern is coming out more and more, we looked at the prevalence of these symptoms in young people, so in children and in adolescents. And you can see that there's a remarkable prevalence of these symptoms among early adolescents, late childhood, early adolescents, which falls down during later adolescence to about 17% on this systematic review. We've actually found higher rates, and falls down a little in later adolescence, and then down to the population average, if you like, of about 5%. So we don't quite know what is behind this very high prevalence in the young children, and I think we need to investigate more about this. There's actually very little known about the prevalence of these below the age of 8 or 9 of these symptoms. So this is quite an old study now, but I suppose there's still not that much on prodromal risk symptoms in the general population. So this is Dublin, and when I came back to Dublin, we wanted to recruit to look at this prevalence of these symptoms in school children. So we went to schools up around North Dublin here and West Dublin. The hospital we're based in is about here, so it's kind of in our catchment area. Just general primary schools. And we wanted to look at the children in 5th and 6th class, which would be 11 to 13-year-olds, because when I was in the UK, I had been involved in the Dunedin sample, and that classic paper from the Dunedin study showing that symptoms at age 11, psychotic symptoms at age 11, predicted later schizophrenia, schizophrenic disorder. So I thought there may be something special about this age group, this 11, 12, 13-year-old age group. So we went to these schools, and there was no screener at this time, so we kind of invented one using the questions that the Dunedin group had used from the disc, and adding a couple more about grandiosity and visual hallucinations. And I just gave the kids this, handed it out in the classrooms, and they had to tick no, maybe, yes to each of these symptoms. And we had no idea what kind of prevalence we were going to get. So we screened 1,131 and found that 22% of them had screened yes to one of these psychotic symptoms, which was amazing to us. But then we wanted to find out whether these translated into anything on interview. Maybe they were just ticking the boxes for fun, or maybe they didn't know what the questions actually meant. So we brought 212 of them in for interview, which was luckily representative of the entire group in terms of their scores on the adolescent psychotic screening questionnaire, and also they were representative of in terms of the strengths and difficulties questionnaire. So we brought them in for a detailed interview, and the interview was the kiddie SADS. It's stuck. Sorry, I think it's got stuck on me. Anyway, so the interview we used was the kiddie SADS, which was and we added some questions. Now the thing is, if any of you know the kiddie SADS, it's the Schedule for Affective Disorders and Schizophrenia. It's mainly, but it's very sketchy really. The screener's only about 2 questions long. So what we did was we added in extra questions from the SIPs, because we'd been to a SIPs course. Barbara Walsh had visited Dublin. And we also added in questions about functioning and distress. Well, no, there is a functioning element. The global assessment of functioning is Oops. Sorry. Oh, great. Yeah, okay. So I'll skip that bit. So that's our distribution. As you can see, it's very much fits the half normal distribution that I mentioned earlier. And 71% of the kids with symptoms had auditory hallucinations. That's incredibly prevalent among this age group. So the Kiddie SADS was the interview. We included their global assessment of functioning. Our interviewers were trained from a psychology or psychiatry background. And I say we had supplemented it because we thought it was a little sketchy. We supplemented it with for questions from the SOPs and also questions on attributions, frequency, onset, distress, because these were particular interests of ours. And the other key thing is we took a detailed description of the symptoms. So if the child came out with any symptom, and we always wanted to have a second person sitting in the interview who could transcribe as the child was talking. So we had a detailed description of the symptoms, which came in very useful later. And then, so this is an example of, this is one of the first kids that we saw, and I say we'd no idea what we were going to find. And then the interviewer, I think it was Ian, actually came out and said, oh, gosh, this girl had really quite prominent symptoms. So she was hearing voices, which started when she was age 8 or 9. She was now 11, so 3 years. It used to be screaming, and now she was hearing words and sentences, different voices, all male, and they kept her awake. And then she was beginning to see faces, so she was getting visual hallucinations. And she was waking up in the middle of the night, and she was getting frightened. She said, I close my eyes, cover my ears. She said, I'm afraid most nights. I think something's coming to get me. So she's beginning to develop depressive symptoms. And now, and worryingly, she said, I don't think anymore it could be my imagination. I did in the past, but it kept happening. So I definitely don't now. So she's passing that threshold between what could be attributed to her imagination and to something that she thinks is real. So this was what we would call a strong psychotic symptom. Now, there were other kids who had symptoms that were kind of weaker, and we had to have a consensus meeting about these. But we didn't rely on just one person's opinion on whether a symptom was a psychotic symptom or not. And some of them were very hard to figure out. We'd have lots of arguments about them. For instance, this one that, I was playing with friends in the garden. I heard a voice saying something very faintly to do with the game. I must have said it in my mind. The other girls didn't reply, so I hadn't said anything. So this is a very weak symptom. And in fact, the next one is this young chap who had what I suppose you could think of was grandiose, delusional beliefs that he would beat Carlos Tevez or Wayne Rooney at football, and he was quite definite. He was better than all other players except Messi. So I was wondering what to make of this young chap, I suppose we'd like to get him back in and was he talking about a computer game perhaps, or did he really believe he could play football better than everyone except Messi? And in fact, the IT technician he was very pleased. I had 2 Argentinians on my slide. Apparently Carlos Tevez this chap here he's Argentinian too, and now gone back to Argentina. So anyway, that kept. I don't know if there's any. Though when I showed this slide a few years ago, someone screamed at me, "You're wrong!" In fact, Tevez had at that stage left Man United and had gone to Chelsea, so there was a mistake. I should have. And now he's in. I don't know who he plays with in Argentina. Is it some team in Argentina? Okay. Anyway, the symptoms. The good news is the symptoms that we picked up on the screener are very predictive of the symptoms at interview. So they're useful symptoms, okay? So if a kid ticks a box on a questionnaire saying, I hear voices when there's or sounds when there's no one else around, they will have something on interview, a psychotic symptom. So that's great news. And the other questions that are useful are the ones about visual hallucinations and the one about spying or thinking someone's going to get you. Some of them weren't so useful about the, hearing TV things through the TV or radio. That wasn't a very useful question. To be honest, kids don't listen to the radio anymore, and that was an old-fashioned question. And mind reading, they don't tend to think too much of that. So they're the 3 useful questions. So we found 22% had these symptoms. Now, okay, to get down to the meat of it, we had another consensus meeting to apply SIPS criteria to our interview transcripts, okay? So, and we sat down and did this blindly and separately and came together, and then we decided that 8% of these 212 kids picked up from a normal primary school in Dublin fulfilled criteria for prodromal risk syndrome. Now, that was surprising. And then Ian went off and applied the CARMS criteria and got about the same rate, the 7.7%. And I suppose cleverly, and then decided, now these are too high, and so he applied the criterion. It was quite a new criterion at that stage, I think, about the deterioration in functioning. So he decided to apply that, and then we got down to a figure of about 1%, which I suppose. So it shows the crucial thing is to factor in functioning when you're especially in this age group. The other interesting thing was that we found that. Of the kids that fulfilled the criteria for a SIPS prodromal risk syndrome, about 7% of them had the APSP, the attenuated. This thing is a real tongue twister. Attenuated psychotic symptom syndrome. Anyway, you know what it is. I can never get my head around it. It's really APSPS, I think. Anyway, so and in fact, they were the ones who were. It was more likely to have the decrease in functioning and the comorbid psychopathology. Whereas the kids with the BIPs, we had 40% of the kids who fulfilled criteria for a prodromal risk syndrome fulfilled criteria for BIPs. Now, this is actually very rare in your normal kind of early detection service, or you know, but it's actually quite common in this group, and they tended to have better functioning. So that was interesting. And so in general, of the young people with the prodromal risk syndromes, 63% of them also had another disorder, because we had used the kiddie SADS, we were able to get information on depression, anxiety, behavioural disorders. So sorry, I forgot to put it in the slide, but 37% fulfilled criteria for an affective disorder, 32% for an anxiety disorder, and 21% for a behavioural disorder. So a high degree of comorbidity among the young people with these prodromal risk syndromes, or this so-called prodromal risk syndromes in the population. Okay, and now I suppose what's interesting is that I just saw this study from the German group. Interesting because they looked at kids as well, called the Bears Kids Study, and this was looking at, again, the prodromal risk syndromes in the population. And they found, using a mixture of telephone and face-to-face interviews, they found that 1.3% of the sample fulfilled criteria for a SIPS prodromal risk syndrome. Now that I couldn't find in the paper, I'm not sure if any of the authors would be here, whether they looked at the kids separately to the adults or whether they merged them together. But what's interesting here, and it's what we found as well, that they found the prevalence of at least one ultra-high-risk symptom was 22% in the under-16s, again, very similar to our findings, and 7 to 10% in the over-16s. So there's this shift, there's a real change in the prevalence, and it's mostly what they called perceptive symptoms, what we were calling hallucinatory symptoms. They're very much more common than we'd ever thought in these young kids. We really haven't got to the bottom of this yet. Okay, so what do we need to know about the symptoms? So I suppose we're looking at this youth population of whom, up to 1 in 5 could possibly be having psychotic symptoms. And among those, there is this group of about 8% maybe who have poor outcomes and possibly a prodromal risk syndrome type picture. And then among them, who's going to develop psychosis? We still don't know that. And we don't have much information on... Does this mean I've run out of time? I'm down to 22 seconds. All right, okay. So we know in general that there is a higher risk. Young people with who report psychotic symptoms are at higher risk of later schizophrenia-form disorders. 16-fold increased risk in the Dunedin study, which is a New Zealand birth cohort, and of the young kids at age 11 with the symptoms, 25% after 15 years would meet criteria for a diagnosis of a psychotic disorder. That's a very, very high amount, though the numbers were small, and it's relatively specific for psychotic syndromes, particularly the stronger symptoms. The weaker symptoms were less specific. And then Helen Fisher's work, following the Dunedin sample up to age 38, still finds this increased risk of schizophrenia here, significant increased risk of schizophrenia at age 38. They also, interestingly, found an increased risk of PTSD and also significantly increased risk of attempted or completed suicide. So these are not... okay. And this is an Israeli study, which is a very large population-based study looking at risk of psychosis, psychotic disorder, which was hospitalized in people who had reported psychotic experiences on a kind of survey. And they found, again, similar, it's Werbalov et al., about a 10-fold increased risk of hospitalization for psychotic disorder if you reported what they called a strong symptom on the survey. But I suppose there's a lot of caveats in this paper, and they said, well, look, it's only 1.3%, and the population attributable fraction is actually very, very low. But what I think is interesting is if you look here at the 22 people who were hospitalized for psychotic disorder, 18 of them had reported either a weak or strong psychotic symptom earlier, so 80% of them. So what you're looking at among people with psychotic symptoms is that they're the population from which pretty much all the psychotic disorder will come. But of course, we just don't know which one. So that needs to be a focus of future research. And interestingly, Stan Zammit has found very similar things in the Alsbach birth cohort in England. He found, looking at symptoms at age 12 in relation to psychotic disorder at age 18, that 80% of those who were diagnosed with a psychotic disorder, a clinical diagnosis at age 18, had reported a symptom at age 12, either strong or weak. And he also found an increase, it's a 5 or 6-fold increased risk. Now here, Stan had, again, he calculated positive predictive values and finding, it depended, I suppose he got, it was about 5% if you just took psychotic, the presence of a psychotic experience. But he was able to get the positive predictive value down to up to 22% by looking just for those with very strong, very frequent symptoms. So it is, but the numbers were very, very small. So he's moving towards this idea of making a predictive model. Okay, persistence. So I think I'm kind of running out of time, but we have found one other thing, a side effect, I suppose, of our study, and again, the usefulness of looking at not just psychotic symptoms, but at other disorders, was that we found very high comorbidity between the psychotic symptoms and other disorders in the young people in our studies. We found that that young people with other, that there was a strong link between particularly affective disorders, you can see here, in these two studies, our adolescent brain development study and another adolescent study, and psychotic symptoms. So young people with affective disorders were very much more likely to be reporting these psychotic symptoms. And particularly young people with more than one disorder. So if a young person had depression and anxiety and a behavioral disorder, they were, more than half of them would also report psychotic symptoms. So it's a marker for multimorbidity. Okay, and worryingly, suicidality. So these kids were 10 times more likely to have a suicide attempt or a suicidal ideation. But of course you'll say, well, of course, you've just told me that they're more likely to be depressed. So of course that's what's driving the link with suicidality and suicide attempts. Well, what Ian did, Ian Kelleher, he used a large birth cohort. We didn't have the numbers to stratify in the ABD study, but he used the SAIL study of 1,000 young kids from the south of Ireland. And what he did was he just cut off the top 20% of psychopathology. So he took just the kids in the cohort, they were 14, 15-year-olds, who had scored in the top 20% of the Strengths and Difficulties questionnaire, indicating that they have high levels of psychopathology. And he looked within that group, and he sliced them into those with and without psychotic symptoms. And the beauty of this study was that it was not only quite large, but also was longitudinal. They followed the kids 3 times over a year. And they were very interested in suicidality, because this was part of a larger randomized controlled trial of, it's published in the Lancet there about 2 years ago, different interventions to reduce, you probably know it, reduce suicidality among kids. So that was their focus. They weren't interested in psychotic symptoms. It was only the Irish Centre who included a question about hearing voices. So what Ian found was that when you slice them into those two groups, that the young people with high levels of psychopathology but no psychotic symptoms had a 13% risk of suicide attempts over a year, whereas the kids with the psychopathology and psychotic symptoms had a 32% risk of suicide attempt. This is an actual attempt over a year. So these are a high-risk group, and if you look at it in terms of, mild cognitive impairment leading to dementia or pre-diabetes, diabetes, you're talking, this is higher than any of these other kind of at-risk states. And so I think we need to be looking at this combination a little more. Okay, clinical implications, I'm nearly done. There are important risk markers for a wide range of non-psychotic disorders, particularly for severe and multimorbid conditions. Psychotic symptoms should be considered a core element of suicide risk assessment in young people. And the development of standardized approaches is important, and we're kind of moving to that ourselves. Ian has and myself have been working on a kind of standardized approach to assessing these symptoms called the Socrates. I think I may get to that in a sec. But anyway, so at risk for psychosis. Now, they are at risk for psychosis. Okay, young people who have psychotic symptoms are at risk, higher risk for psychosis, but the risk is small. That's the problem here. And you know, in the Israeli study, they found positive predictive values of 1 to 4%, and also back around 5%. Again, they could get it higher if they took a really small number. So the use of biomarkers and information, neurocognition, or imaging may help to increase prediction of transition. But you know, I suppose Alison may agree, from the current work on I don't think neuroimaging has really fulfilled that role. I know Ty Cannon's been publishing it, but it's mainly the clinical. I think the clinical symptoms will help us to predict transition. So we need to get more detailed information on the clinical and phenomenological aspects of these symptoms. We need to know more about them. And this is more useful for clinicians as well. And so, as I mentioned, Ian and I decided we'd try and just get our thoughts together, and we've devised this protocol for assessing these symptoms in young people, which is available from our EPUBs in RCSI, which is it's free access, and it's looking at that's the other Socrates. So the source. So these are things you should measure, and Ian has written little explanations under each one: the source, the onset, duration and frequency, the content and character of the symptom, reality testing, attribution, timing, effect on functioning, and severity of distress. So if you have this information, you get a much better picture of the symptom, not just present or absent. Okay, so as I say, I suppose what I'm trying to say in my inarticulate kind of way is it's not that easy. We can't just move in with cancer and say, oh, kids with psychotic symptoms, screen for it and bring them all in and treat them somehow, and you know, because there's too many of them and we don't know what it means. It's not and even with cancer, there are problems with screening for cancer. There are risks in terms of screening, and I suppose this case particularly sums it up for me, that the risks and the dangers of moving in too fast before we know more about what's going on with these kids. So this is a young child, NS, who as an adult is talking back about symptoms he had when he was a child, when he was age 8. And he had this very elaborate visual hallucination of a carriage with 6 white horses and footmen dressed in finery passing by on the road. He remembers being on the side of the road. He said it was quite beautiful. I remember how extremely clear it was. I heard the sounds of hooves and muted voices, so auditory hallucinations too. The carriage was moving slowly, and once it passed, another one came along. So this went on for quite a long time for this young boy. He remembers it. This was like in his adulthood, yeah. And he said when he pointed out the site to the others, so there were people with him, he pointed out these carriages and footmen, and he said they looked at me puzzled and told me to stop talking about it. Now, we would have rated this as a very strong symptom that this child had experienced. But just to put it in context, this young boy, it was in Czechoslovakia, it was during World War II. Himself and his family and others were hiding from, I think, the Nazis, obviously, were coming, and they were hiding at a time of incredible stress. But he remembers this. And actually, does anyone know? I've presented this before, so someone must know who this young boy is. No? No one knows? Okay. All right. Well, this young boy is actually Norman Sartorius, who ended up being director of the Mental Health Division in WHO, and has become one of the most prominent and most influential psychiatrists of his generation, I think. I mean, I would agree with that, but it's been said. He also was head of the World Psychiatric Association. And he wrote this little piece is actually in the foreword to his book about stigma and psychiatry. It's really interesting. And he said, what would have happened to me if I'd been brought to a hospital, kept there for observation, maybe given some treatment? Could the label of being kept for observation in a mental institution have changed my subsequent schooling, social relationships, and working life? So that's a big question. I suppose I will end there. Thank you.
I think in the interest of integrating the presentations into the symposium, we'll have questions and discussion. We'll have plenty of time at the end. So I'm going to be once again Jay and do my part of the presentation. Can we have the presentation up? Okay. Well, as you can see, Jay looks very different from me. I insisted that he send me his picture so I could put it in the presentation. But anyway, the work that I'm going to present is sort of from our group. I'm not going to go through the introduction because I think we've heard about that, and everybody in this room probably is well aware of the different stages of developing psychosis, and the critical period and the period prior to the critical period is what the ultra high risk and the prodromal, which is really a retrospective concept, but the ultra high risk, the clinical high risk definition has been of much greater utility for clinical and research purposes, first started by Alison and Pat. So, okay. I think in a way, Pat kind of alluded to this morning, that we have several assumptions that we need to make when we're talking about isolated disorders, as if they do exist as purely as those, and also as if the precursors to them are also that clearly defined, and that they kind of move forward exactly in the same domain, and that's really not the case. But we have to assume now, I think there's enough evidence that perhaps all serious mental disorders, not only psychosis, are preceded by a clinical high risk stage with attenuated or subthreshold symptoms that gives us a much higher predictive power to say that maybe 30-35% of these will convert to psychosis. We'll probably hear later on maybe from Ian if there's similar work in the bipolar disorder. And the impact of this is that if attenuated symptoms are common, then it is a reasonable site for intervention, especially if they actually precede the syndrome, the psychosis syndrome. But if they are rare, then where do we go? And I think Mary's presentation kind of partly addresses that. We have a challenge that in the general population, many people, young people particularly, will have these symptoms that may or may not lead to a disorder, but may also lead to multiple disorders. And younger you are, the more diffuse the outcomes are. In fact, many of the people, even with psychotic-like symptoms, do not necessarily develop a disorder. So I think this is a sort of, from a service perspective, this is a dilemma that we have to address. And if you go even further back in time, then you have really an undifferentiated distress and people presenting with different kind of states like that. Just to review the clinical high risk criteria, whether you use the CARMS or you use the SIPS-SOPs, are essentially the same. The most common one are the attenuated positive symptoms, which is like the subthreshold positive symptoms, delusions, hallucinations. And then a smaller proportion of clinical high-risk populations have these brief limited psychotic symptoms or blips. And then there is another group that has a genetic, familial genetic risk combined with functional deterioration. These are the definitions that have been provided initially from the Melbourne group and pretty well accepted by everybody else. And this is kind of, in a way, sort of summarizes that the entire prodromal period actually may have two components to it. The early prodromal, which is much more undifferentiated, and the later prodromal, as you get more proximal to the psychotic onset, to the onset of syndromal level psychosis, that it is assumed that people go through this subthreshold level of symptoms. But most of the work in this area has been really by identifying help-seeking people who are demonstrating this clinical high risk. What we don't know is people who develop first episode psychosis, how many of them would have gone through this stage, because that would give us a sense of how important it is for us to intervene and how much impact it's going to have. So if you have 100 people with clinical high risk, we know roughly about 36% of them will convert to psychosis within a 3-year period. The conversion rates have gone down for several reasons, and one of the reasons may be simply that people are identifying this as a genuine mental state that needs intervention, because these young people are actually quite disabled. They have very high levels of distress. They have actually high levels of functional impairment as well. So we know that from, if you look at in that direction. Now, what we don't know is if you take 100 people with first episode psychosis who have actually come into treatment for syndromal level of psychosis, how many of them would have at one point gone through a clinical high-risk state had they been identified at that time? Is it 50? Is it 25? Is it 75? Because that would give us some measure of how much should we be investing in terms of service delivery to actually identify people at that stage. So, as I said, awareness of what proportion of first episode cases could be targeted through indicated prevention initiatives, and that's important for us in terms of if you have the service providers who are the funders of the service providers are going to ask this question, what is the return for our money, so to speak. So I'm going to present very briefly the findings of this study that we conducted and that Jay is the principal author. It's just to give you the context of the study, it's conducted in the Prevention and Early Intervention Psychosis Program in Montreal that I had set up about 14 years ago and has been running since 2003, and a prior version of that was set up in Ontario by me many years before that. It's a catchment area-based sample which gives us a little bit of a perspective on the fact that there are no private facilities. This is the only first episode. This is the only mental health service for psychosis patients in the catchment area of about 300,000. And it's publicly funded. So the ACT people have, as most of you know, that in Canada people have access to mental health, to health services without having to pay, and we do not have, it's probably the only country that does not have a private healthcare system, or at least not officially a private healthcare system. And the referrals to this program are open referrals. Anybody can refer, including self-referrals, family referrals, and people are seen within 72 hours. And we have the first episode population, then we have the ultra-high risk population also that, but I'm not going to present on the ultra-high risk, I'm going to present on the first episode. And what we use on all our first episode samples, by now, I mean, the data I'm presenting is on 350 patients, but now we have about 700 odd patients, most of whom, 95% of them signed consent to have certain evaluations completed. And one of the evaluations is this instrument that Ross Norman and I designed many years ago, Circumstances of Onset and Relapse Schedule. It's partly based on the IROS, the Hafner's instrument, and it actually, it takes about a couple of sessions to complete and interview the patient, interview the family if there are available, and review of all the education and health records which we often have access to. And then we extract essentially a very historical perspective from the very beginning. At what stage did the person start having emotional or psychiatric problems? What did they do with it? Where did they go? So we have the whole pathways of care. And then included in that is we have what we call the TOPE, which is the topography of psychotic episode, which gets into the person having experienced any of these 27 potentially early signs and symptoms of psychosis. These are so-called prodromal symptoms that are not, it's a mixture of non-psychotic subthreshold as well as psychotic subthreshold symptoms. And we have fairly good inter-rater reliability using this instrument, and all decisions are made through consensus with at least one of us senior psychiatrists, myself or Rida Joubert. And we conducted this analysis on 351 subjects on whom we had data out of a 520 total number of admissions to the program at that point. So the first thing we did, there's really three stages to this study. The first thing we did was we wrote to more than 30, I think it was about 32 psychiatrists and psychologists who are known in the early intervention field. It's not exactly a sort of a Delphi process, but it's sort of close to that, and asked them to, out of these 20 odd symptoms, identify which of these they would consider as subthreshold psychotic symptoms or attenuated psychotic symptoms. And we, a priori, we set a threshold that we have to have at least 60% agreement between the people that we surveyed to regard that as a bona fide attenuated psychotic symptom having been assessed retrospectively. And here is the data. We have close to 70% of patients had experienced at least one attenuated psychotic symptom. And that's fairly high, and obviously 30% had not. And you have then a list of relatively small percentage of patients had more than 4 or more of these attenuated symptoms. We have not looked at whether, because the numbers are relatively small, at whether there was a sort of a cutoff at which the outcome in the first episode varied according to how strong the subthreshold psychotic symptoms were. And these are essentially the symptoms that were identified where we had 60% agreement for the experts. And this is the frequency of these particular symptoms in this sample of 351 patients. As you can see, suspiciousness and or bizarre ideas have the highest prevalence, and then lower for disorganized speech and quasi-hallucinations. However, this list basically is all the other symptoms that the same patient population had, and these are, as you can see, these are generic psychiatric symptoms, and including social withdrawal, impaired concentration, and so on, which do not fall into the attenuated psychotic symptom list, but they are relatively lot more common. So as we all know, when you look at retrospectively, our patients have gone through multiple symptoms. In fact, 50% of our sample of first episode patients had gone through a period of major depression at some point. So we have both non-psychotic symptoms, which have very low specificity in terms of psychosis, but we have the attenuated symptoms, these ones that appear to have lower frequency, but they were at least present in 70% of the patient, at least one of those symptoms was present. The next thing we did was we wondered if the patients who report to have gone through a clinical high risk state, once they came into treatment as first episode patients, whether they had different characteristics. And in fact, there was no difference between those who we identified as having gone through a clinical high risk state as opposed to those who did not. No difference in terms of any of the personal or clinical characteristics. I've not put in, because the differences really were not anywhere approaching significance. So that gives you an idea of the severity of symptoms at the time that the assessment was done. So what is the conclusion? The conclusion is that we have had a representative sample of patients, because this is essentially, as much as possible, we are dealing with a treated incidence sample. So everybody in our catchment area who does seek service or is made to seek service sometime is included in this sample. And out of that, it was 68% of these youth, 16 to 35, who had a diagnosis of first episode of psychosis, would have gone through what we identify as attenuated psychotic symptoms or or clinical high risk state. Therefore, we conclude that the clinical high risk state is actually a valid target for early case identification and intervention, because not only because there is a high percentage of conversion from clinical high risk to first episode, but also the reverse is true, that people with first episode psychosis, had they been identified during the ultra high risk, would have captured 70% of them. So that, I think, is an argument for us to advocate for services to expand to this particular, within this age group, to people who meet these criteria for subthreshold symptoms. What are just some reflections on what this all means? As I said, more than 60% of subjects who are in the clinical high risk do not develop psychosis. So that we have to sort of keep that in mind. But even then, as several of us have said, 35% conversion is not low. It's actually quite high. And those who don't convert, we know now they also have relatively poor outcomes. They may not develop psychosis, but they have a great deal of impairment and persisting disability. But up until now, most people with clinical high risk have been recruited in specialized academic clinics. We need to move on to the next stage, which is how do we actually take this clinical knowledge, which I think really is now clinical knowledge, and then apply it in real life, real service settings. And as Mary referred to this earlier, that there are very few studies that actually I think Ian's might be the only one where you actually look and identify clinical high risk states in community samples. What are the implications for health services? I think the implications, in a way, I've kind of sort of alluded to what some of the implications are. We assume that symptom severity will correspond to impairment, but that assumption may or may not always be correct. Just the presence of some symptom, even if it is milder, might actually be associated with greater or as much impairment, because impairment is driven by more than just symptoms. Impairment may be as much driven by social circumstances and other issues. One of the issues here is that this idea of specific high-risk state for specific diagnosis does not take into consideration that in real life that's not how patients appear. That's not how people develop symptoms and have a clean trajectory. So it does not recognize the dimensional or the trans-diagnostic approaches. And also, this in a way forces, if we continue in that line of thinking, it would force us to keep thinking of specific interventions for specific disorders and therefore specific interventions for specific high-risk states. But the reality is that many of generic interventions are actually quite effective. Whether you give CBT after first episode or CBT or even a lighter CBT or even case management. In our program in ultra high risk, we do mostly case management and some family intervention and those who need CBT. And we've been able to bring down the conversion rates to about 10%. So interventions may not necessarily have to be that specific for specific disorders. And I think in terms of the health systems, several people, including our group, has identified that the level of distress, the level or the low level of social support, and perceived stress are as high in the ultra high risk population as they are in first episode samples. In fact, we found on some measures, actually, first episode samples after they got into treatment had actually a lower level of distress, perhaps because someone was able to say, hey, this is what you have, here's this treatment, this is going to work, as opposed to ultra high risk state where we're still a little bit sort of looking for what works and what doesn't. The other issue is again, beating on the same point that symptoms in the ultra high risk state, even for psychosis, are generally, they change, they fluctuate, and they fluctuate particularly in the younger population. If you take the younger 12, 13-year-olds, I think the most common things I've seen in the younger ones is really emotional dysregulation. You couldn't actually, that was the most common and the most persistent presenting problem. And services currently are organized and even paid for in some circumstances by diagnosis. When a physician, at least in Canada, if you want to get paid, you have to put a diagnosis there. If you don't put a diagnosis there, it will be questioned, what exactly are you seeing? So here, I think what we're basically talking in the future about is, are we going to go from this, what has been so far, the splitting, to what, I don't know if it was Jay or somebody else called it lumping, and that essentially implies that there may be a generic clinical high-risk stage from which emerge eventually different disorders. So just to finish, one of the ways to address this, and I think Pat kind of touched upon this this morning, is in the context of developing youth mental health services that are much more generic, and especially if they are situated in primary care, as has happened in Australia, as we're doing in Canada through our Access Open Minds project. And because setting it at that level, first of all, it's less stigmatizing. You're likely to have access to much larger community samples at an earlier stage, and people will come, especially the way these services are set up, for distress, not for a disorder, and that might make it easier to actually identify people early on. And the perspectives are really kind of shifting to long-term trajectories, some of which may not actually be diagnostic trajectories. And it, as I said, it also destigmatizes distress, and but there is risk of many false positives. So I'm going to finish there, and if it's okay with everybody, we'll just continue with the presentation, and we'll have plenty of time for discussion, and we can do a discussion as the whole subject together. So I'm going to ask Ian to come and do his presentation, and if he can allude to Jan's presentation as well through the telephone. Thank you.
Thank you, Ashok. If we can get the presentation up. He's waving a hand. He's showing me a hand. Great. It's a shame that Jan actually isn't here, because the conversation that's been going on between Jan, myself, Jai, and others about these issues, as Pat was alluding to this morning, does go to the central issue of not epidemiology and not specific disorders, but those who are trying to run health systems in various ways and deliver the greatest good for those currently seeking care, and into the future, what care may look like. The idea about whether we need to fundamentally approach the problem differently, both from a classical diagnostic point of view, mainly to get beyond the diagnostic systems that we've had and the treatments that we provide. And then the issue that Bob Hudson raised at the end, if you're going to go to scale, what are you going to go to scale for? What's going to deliver the greatest benefit if you try to go to scale in the services you choose, the affordability and the impact of those services? And so those kind of questions that actually have been preoccupying myself and Jan, in particular in dialogue with Pat and our Melbourne colleagues, and in particular in the Canadian setting, alongside some very important work we've been associated with Kathleen Merrikangas in the US, looking at adolescent epidemiology, about the nature of disorders in the adolescent period, and what you would actually plan services for if you ever were to plan in a place like the US or elsewhere. How would you actually go about that? So I think it's a very important time. I think the difficulty in this setting, for myself and Jan in particular, is the one Pat alluded to. When a society like this looks back over 20 years, it's psychosis preoccupied. And in fact, I think if you look at the abstracts of this conference, it remains psychosis preoccupied, because most of the people come out of service environments that have been established over a long period, principally for people with psychosis. Sadly, historically, as Pat was putting out, with a sort of chronic illness model, but as they move to an earlier recognition model, try and change that course of the illness. If you come at it from a different place, and so Jan would still confess to being largely a mood disorder researcher. Myself, I think I lost interest in disorder-specific things a very long time ago, that actually you see the world considerably differently. So as Pat was alluding to, I spend most of my time these days with political and social systems about trying to drive investment in mental health. And the question is, for what? Well, the one that we discuss most frequently with places like Treasury and Finance has to do with the cost of mental illness and the distribution about that. So as Pat was alluding to, we're very lucky in Australia currently, in my view, to have a Prime Minister, our current Prime Minister, because we change them pretty frequently, who's preoccupied with the notion of mental wealth. In fact, what's driven Australian investment over 20 years, over a much longer period, in fact, well, longer than that now, right back to 1993, is the fact that our federal government pays the welfare bill. It pays a large chunk of the health bill but it pays the welfare bill. It essentially pays for failure of people to progress from childhood and adolescence to normal economic and social independence. So that failure to go to participation costs. So the classic kind of issue which we deal with in Australia is if you're going to invest, like every other country, you get worried about dementia, you get worried about ageing and the costs of ageing, although that picture is actually changing progressively. Very good for those of us who are still on this side of that curve. It's actually changing. Brain health is actually improving with age. What's been much bigger from an economic point of view, and really at the heart of a lot of OECD modelling, is the failure to change the curve of disability costs in the late adolescent and early adult period. Some of it preceded by childhood onset disability, but a large chunk of it becoming obvious during that particular period. So if that's what costs, and that's what really ruins people's lives, that becomes the focus. And it's not really diagnostic. It does mean that those areas of child, youth and ageing are the ones from a social point of view. We need to be asking ourselves the question, are we making the most difference? Epidemiologically, public health, population health, but also health services. Oops, sensitive little button. So, of course, the epidemiology matters to say, you know, when you get to that disability and onset issue, that basically that adolescence is the big age of onset. And I think the epidemiology of the last 20, 30 years has been helpful to really focus the idea of onset. And in most illness situations, for most early intervention to reduce disability, you generally want to be there closer to the onset of that problem if you're going to manage not just the problem, but the disability. In fact, in a very important discussion I had with our own health minister recently, who's sort of a bit confused about this whole early intervention bit. She's got the idea it's about preventing illness. And I was saying, you know, prevent illness, maybe reduce symptoms, is actually about living better with the symptoms that people might actually have so they function. And she said, oh, just like any other illness, because once you get to a certain age, you've got symptoms, you know, it's about whether you go to work every day or not. I said, exactly. But in order to do that, in order to ensure that young people actually go to school, go to work and participate, that's actually in many ways a bigger focus of early onset than necessarily whether you prevent entirely a certain kind of illness course. From a social point of view, that's the sort of thing. She said, we're going to investing in that as a health system. That's something we could do. We need to invest in our social welfare systems and our education systems alongside that. In fact, for that adolescent onset for young men and young women, all these different colours are different disorders. Of course, what you see from a neurobiological point of view or a social development point of view is it probably doesn't have much to do with the individual colours of the disorders. There are probably big neurobiological processes and big social processes running through that post-pubertal age group that actually have to do with the onset of that disability. It's unlikely that many of them are very diagnostically specific. So in thinking about our particular kind of work and taking this whole idea to other areas, what the other situation is to say, what the hell are we actually trying to achieve here? Most of the conference here, and I think most of the 20 years of this conference, been somewhat preoccupied with number E, which is trying to stop the onset of schizophrenia and its very bad outcomes over a long period. And the psychosis preoccupation remains down there. I'd suggest to you that while that's very important, and theoretically it's very important, society is more preoccupied with the A to D these days. And if you're a parent or you're a family member of someone with a child with the onset of or a young person with these problems, it's those other things that really fuss you. And from an economist's point of view or a general social point of view, people would suggest it's the top one that should preoccupy us all the most. That actually, as a result of what happens here, do you end up with independently socially functioning adults? In actually planning our health systems and everything else, suicidality, and it's emphasised by Mary just recently, actually suicidality is probably out there in the community, something that people understand the most. The tragedies of attempted suicides and completed suicides in this area, and the notion that we should have somehow done better is very important. Concurrent substance abuse, big issue, increasingly and appropriately a focus on physical health outcomes. So I think when we're talking about what is it our health services are doing, it isn't just are they preventing progression to a particular illness. There's an expectation, if things expectations weren't bad enough, that we also do other stuff across this whole range that results in those better outcomes. So taking that forward in terms of thinking about that, there's also a bigger issue that, you know, really the diagnostic sort of approaches and the general prescription of treatments that we have are really not very personalised. They're really rather provided in a rather generic kind of way. Can we do better at that? And one of the issues that Ashok just alluded to that preoccupies us is actually got to do with trajectories. Not which illness do you have or which label do we apply, but what trajectory are you actually on? And can we understand that better? And at the moment, I think we have a big gap between the sort of diagnostic concepts, which are non-trajectory based. You know, a child with psychotic symptoms, at least in one of the NIH frameworks, can be the same as a 40-year-old with chronic schizophrenia because they share the same symptoms, which which is clearly at another level ridiculous. They're nowhere near the same sort of thing. But the classic diagnostic approach does that, and probably in the affective disorders we've seen this much more severely played out in the so-called child onset bipolar disorders and the treatment of young children with lithium, etc. in that group by saying they've got the same symptoms, therefore they've got the same illness, as distinct from what trajectory they're on. Clinical staging is developed by Pat and myself and our Melbourne colleagues and our Sydney colleagues, and certainly with Jan and others, has been about the application of that notion of trajectories in the clinic. When you see someone at some particular stage of time, what they have is not simply an age-related phenomenon, but may well be a stage-related phenomenon. What degree of symptomatology, or more importantly, what degree of syndrome have they reached? What sort of disability, and would it make a difference to treatment selection? We've got another issue going, and it's the one that Bob alluded to also, is if you think you can do that, there's really a population issue. You're going to have any sort of population impact. And a lot of the pushback in Australia has been to say all these new services really have no population level impact. There's no evidence they're making any difference to the curve costs on a particular kind of way. How would you go to scale? And I think as you plan services, you've got to think about that. I was intrigued with Bob's slide this morning of 180 services or something in the US. 180 services isn't going to give a lot of population coverage, in truth. And depending on the effectiveness of each of those services for the particular thing, you know, as you put in more and more money, or you ask society to put in more and more money, you've got to think about how you're actually doing that to achieve what outcomes. So one of the big issues for us is not just the headspace services that Pat was talking about this morning, but as he alluded to at the end, to what extent can we automate systems, use technology in effective ways to get to the right people at the right time to potentially also get better outcomes. So I thought, along with Ashik, I should go find a picture of Jan in case I couldn't find, in case she didn't turn up. But it's been important to say that there's been is now a transcontinental kind of development. Now I'm going to just go off and talk about Jan here for a second, as she's been sending me texts wildly. Anyone who works in the NHS, she's sitting at her mother's bedside and can't get a decent internet connection from an NHS hospital, so we would like to fix that. But she's been looking particularly in the affective disorder area around psychotics, about psychotic symptoms and then related disorders. And the other debate that Pat was alluding to about this early onset issue, that age per se doesn't sum the whole thing up. And certainly those with affective symptoms, many of them have the age of onsets of syndromes that are called psychosis at later ages. Certainly in women, she's just sending me another message as we speak, in the late 20s kind of period and into the early 30s kind of period, and some of those disorders don't fill the syndromal criteria till later on. And it's been argued, therefore, the sort of narrow focus we have on adolescent services misses those groups and doesn't do the same kind of thing. We've had a lot of the same pressure in Australia as these headspace services become more engaging and more important. Can't they be extended to taking those with later onset? And certainly can't they be extended for those who actually had onsets to a later period? In our own particular services, we tend to run them up to 30, not 25. Jan's written back saying one of the things, two things, is to say, basically, she thinks that's a wrong-headed model. That's a diagnostically preoccupied model. The life issues that you face at 25 and 30, where you are in life in terms of your life course, your social relationships, your service needs are actually quite different, in fact. So her kind of view would be what we really need is an expansion of the services in the younger age group, but for them to be much more transdiagnostic. Not to say you get into the service if you somehow meet our psychosis at risk criteria, but you don't get in. It's Andrew Channing. The moment you're called personality disorder, you're not coming in. Or the moment you're called some sort of affective disorder or bipolar disorder, you can't come in because we only have a special service for the psychotic kids in a particular way, which is an interesting thing. In a number of young person groups I'm associated with, people are not as, or people are smarter than we often give them credit for. If that's what's required to get in, that's what you bid. Or the smarter families and clinicians tell you what to bid in order to get in particular ways. What is it I require to get into your service? So you've got to be careful always that you don't actually create certain kind of things. And then you get the problem that was been alluded to by the Norma Sartorius example. If you use a psychosis-only label, are you saying you've got the psychotic disorder and you really are the same largely as people with chronic schizophrenia in the long term? The psychotic symptoms have some special kind of particular relevance that doesn't really apply. So there are all sorts of challenges that are raised in these particular sets of areas. So in the clinical staging model we've developed, which is for clinical populations, the epidemiology is another issue, and I'll allude to this in a plenary session on Saturday and elsewhere, and we are ourselves involved in a long-term study of adolescent twins. All those symptoms, psychotic symptoms, symptoms of manic activation, other affective symptoms, suicidal thoughts are all common in the population. How they cluster and how they develop over the adolescent periods, which ones persist, which ones actually are transient, how they lead to disability, is something we are following in epidemiological populations. But I suggest that's a slightly different set of issues to the actual clinical services that you set up. The preoccupation we had in developing these frameworks originally was to say, look, we are interested in a threshold idea, that there's something which we have called a kind of 1B, which has probably got the combination of attenuated symptoms plus some degree of established disability, which for us translates to an obvious need for care. And it's actually that association with disability, so as Mary was showing in her data earlier on elsewhere, that actually to us says, for God's sake, do something now. Because in the longitudinal studies, we won't go into detail here, but discuss again on Saturday, if you don't do something, they will not spontaneously improve, and their function will continue to deteriorate. So it's a symptoms plus function that we would argue. But we're arguing at this point that this may not necessarily be inevitably progressive. We're really interested in whether you intervened at this point, would you change the outcome as well as affecting the illness course? So we've been recruiting people through these particular headspace type mechanisms. Just to show the specialist building that I work at, I was an MRI scanner and other things hidden away in it. In addition to just making up these clinical frameworks, we've been trying to track the neurobiological correlates of these different sets of stages over time. And so we've got into a whole area about what's the neurobiological validation of some of these staging issues. And for those who really want to go into detail, one of my PhD students, Frank Iafino, marvellous Italian name, has just written a large review, but it's about all of these sets of domains and the neurobiological correlates. I won't go into great detail here, but it does assume, and we assume, that there are actual trajectories, that some have childhood onsets and through to the adolescent period. And if you take those trajectories, so we don't assume that people are all the same. I just want to make this clear in the staging models that we pursue. We do not assume that pathophysiology is the same in all those people, but we assume that there are a number of important underlying sets of issues. Some developmental, my favourite one's tied up with development of circadian systems, affecting particularly bipolar type phenomena, and anxious sets of symptoms. The important thing being, at early stages, they're quite mixed. Now, we don't type, my epidemiological friends and Kathleen here, we don't quite go with this notion you only get non-specific symptoms, then you get specific symptoms. I love Mary's data. The kids have psychotic symptoms. A lot of our early adolescents have quite distinct periods of activation. They don't get manic symptoms only when they're 19. They've actually had them for a long time beforehand, but the whole thing hasn't become syndromal and persistent. So the notion that you just go from non-specific to specific symptoms, we don't actually think is right. That actually all of those so-called specific symptoms are actually there, but they don't kind of cluster into a syndrome. When you start to do the research in this area, and our research is largely focused at that 1B or attenuated syndrome type level, you're going to see very mixed symptom patterns. So we are not trying to take that group and suddenly call them psychotic, non-psychotic, bipolar, non-bipolar, etc. But everybody else does. So in the course of my year, I get to go to the bipolar disorder meeting, the anxiety disorder meeting, the PTSD meeting, there's early psychosis meeting, not so much to the schizophrenia meetings. And everyone's looking for the early stage or the service to fit their particular bit, or the eating disorder meeting in some particular way. You know, fundamentally, as Pat was saying this morning, we don't think that's right. And I would say it's never going to work in health systems. Thousands of individual clinics for all those things, as if you could put all those kids in those particular categories at this stage, we think is wrong-headed. Concurrently, we've been doing a lot of neurobiological brain imaging, neuropsychology, circadian assessments to see what the brain correlates are at this area. And just for time's sake, I'll skip through a lot of this particular issue. But just to say, we've been looking at neuropsychology, brain structure, MRI, circadian systems, comparing continuously these different staging models. Now, this means there are kids in there with psychotic symptoms, affective symptoms. We try and break them up and put criteria diagnosis on them, main of which, anyone remember the original DSM? They all would end up NOS actually, and frankly, not otherwise specified. If you truly, they don't really ever quite meet the specificity of many of the adult type criteria. Just a brief summary, what you see across all of these slides, I'm going to flick through this one for neuropsychology, are differentiations between the 1Bs and the more established or persistent disorders, established to stage 2 or 3. So we see that for neuropsychology. I'll talk about this further on Saturday, but neuropsychological function for us, of all of those things, other than function when you come in, best predicts course, not diagnosis, not symptoms. So the neuropsychological aspects when you arrive is a very strong predictor of where things go. In terms of the imaging findings we've been looking at, and in a sense picking up, I think, Asher's comment, why neuroimaging will fail is it pretends to create categories that don't exist. The moment you put in kids who've got broader range of syndromes, you'll find you'll find varying degrees of fronto and other grey matter changes, frontotemporal, also white matter changes. What we see, however, is they are related to the stage of illness. So earlier stages have less severe changes, but earlier stages are not the same as controls. So there looks to be a progressive pattern. And that's something we're trying to sort out more in longitudinal data. In the circadian systems we're studying, same thing in terms of delayed sleep phase and progression. Earlier stages are somewhat, in the sleep cycles, are not that different from controls, but once you get to the stage 1B and onwards, the sleep pattern is different, and more important, the melatonin pattern of onset is quite different as going. So the underlying neurobiology is changing. I'll skip over the physical health bit, just to then say, we've been taking this into systems. So Shane Cross, who's a manager of one of our Headspace systems, a clinical psychologist and PhD who runs these issues, has been looking at what happens if you take this framework. Can you take this framework, in our case, into a regular Headspace system and use it as the basis for organising services? So he's been looking at what actually happens in these particular areas. And then, you know, is it feeding back into what we think? The goal originally, Pat, Alison, myself, Chris Pantelis, was to not over-prescribe too early. Just because a person had psychotic symptoms or had some other particular feature, some manic activation, they wouldn't inevitably get an antipsychotic, or they had some depressive symptoms. Importantly here, what we have seen is that much greater use of psychological services in the earlier stages and more use of medicines in the later stages. When we've looked at the course over time, what's become important is to take those in terms of distress, what actually happens to the 1As are the classical anxiety and with some depressive symptoms but no real disability versus those. Everyone, as they come into care, basically on a group level, has a reduction in distress. What's different is the course in change in function. So those who came in early with a little reduction in function have a reduction in symptoms and their function stays fine, whether they're in care for a short period or a longer period. In the 1Bs, those sort of attenuated syndrome people, they come in at a lower level of function. Those who stay in care continue to have their function improve. Those who drop out of care fairly quickly, it doesn't. So this group is not a group, if you're going to be serious about it, you can just put in a little bit of service for a short period of time and expect their function to improve. Their symptoms will go down, but their function will actually not. And this is the group we've become most preoccupied with. If this is what the whole game's about, is taking those who are at risk of really significant long-term functional impairment, we're going to have to do more over a longer term. A little psychology, a little medical interaction, a short-term sort of dealing with the episode that brought them to care, often around suicidality, won't be enough to change their long-term function. So we're trying to take this into pathways. We have pathways now about how we take this into algorithms, what we do with the particular set of issues, and what sort of treatments we try and match to the symptom sets they have. And this is from Shane's work. I just want to allude to the fact, oops, skipped over there. We're mainly talking about what happens to this 1B group over a 12-month period. And he's been studying the transition kinds of what happens from one stage to another. Now, the interesting thing is if transition's actually happening in this sample, it's actually happening fairly early. So it's happening really, and it's really happening fairly much, I'll show you in a moment, in the first 3 months after presentation of care. So while most kids who are coming in are benefiting, there are some who are coming in who are going down the tube early on in that particular area. And the rate of transition in this thing was over a 12-month period to a later stage has been about 18%. In other studies we've done, which has been variously sort of 15 to 20%, you see a worsening of that particular illness over time, which is reflected in the symptom and the SOFA sets of data that run with that. Oh. The point about that slide, which I just failed to make, is when it's happening, it's actually happening early. So there's this issue about, you know, the ones who are really in trouble, staying engaged with them also when they're actually getting worse. Whereas we have packages of care and a sort of psychology light approach to much of this, which is around engagement and short-term management and doesn't really see necessarily those who are deteriorating or those we need to stick with over time. Now, when you start to do all this at scale, you're going to have a lot of people. My earlier slide, which really had a sort of series of triangles, is quite different, I think, you remember, to Pat's slide, where he had sort of a lump of people this morning all emerging, as if the prevalence of all those things is the same. I'd say it's not the same. The prevalence of all the higher 1A, the earlier things, is much higher. As you go down, there's a lower prevalence, probably from about 50% of adolescents having, you know, diagnosable or significant syndromal problems to only 25% as adults. It's only going to be half as many people. But if you start to manage it there, it's a lot of people in the adolescent period, potentially. So the other big development for us has been developing technically based services. So there's the picture Pat was showing of Jane Burns this morning, who leads our cooperative research centre around technology. And we want to engage people often when they are suicidal, but we think in terms of managing need, the other issue is how much of the services are we going to be able to take online? And for those with lighter need, who can manage a lot more of the psychological services and other issues, at least for brief periods, through supervised and well-managed online services, which we estimate to be about 50% of the load, we reckon we can do that in much more efficient ways. The point being, we would then devote much more of our clinical and complex time to those in that 1B who are deteriorating or with worse functional outcomes. And we need to do it in different ways with education and employment partners to get functional outcomes. So at this stage, we're moving to actually the implementation of this transdiagnostic model. We're trying to do it at scale. We think we have some preliminary validation of the staging issues, which does a better job neurobiologically, but more importantly, we're dealing with the issue about can we actually implement it at scale in clinical service settings. Thanks.
At this stage, I'd like to invite questions for all the three speakers, and hopefully the questions will stimulate some discussion. The presentations were kind of in some ways complementary, in some ways dealing with different aspects of the same issue.
Can you hear me?
Yes.
Yep. Thank you. Terrific. All three presentations are terrific. I wonder if still on the topic of silos, we're still somewhat stuck in the silos, because if you look at the titles of people's talks, it's about mood and psychotic disorders. It's still not psychopathology and outcome or psychopathology and functioning. And I wonder if we still struggle to move beyond the psychosis framework. We tentatively move into mood or particular mood disorders, but we really neglect whole areas of psychopathology in terms of thinking about real, genuine transdiagnostic approaches.
Can you come and talk to all the young people I work with? Like, you know, I do these things where I try and produce these papers in which there's no diagnosis, right? And they send them off to Schizophrenia Bulletin or the Journal of Affective Disorders or International Bipolar Disorders, and they send them back and go, it's not right. Because everything else in our journal compares this bipolar group with that, or this schizophrenia with that, etc. So I think it's a major conceptual kind of problem. And of course, our service environment, and you know, most mental health services around the world are based in the secondary care sector. That's where their long traditions are. And moving, as Pat was alluding to, in the primary care, let alone into the community, isn't where we've been. So I think it's an enormous journey. So, you know, but the biggest issue we get challenged over every day, we send off papers where we actually just have symptoms and function and then have suicidality or some of the stuff metabolic, immediately comes back from the journal, meaning the way we therefore construct it, what's the diagnostic framework? Have you allowed for the particular diagnosis? You know, which particular thing did you force them into in a particular kind of way? And if Jan was here, I'm really grateful for Jan because she's defended us against a whole lot of British journals to get some of our work published on the basis they do know what they're doing. They're just not choosing to narrow the field of inquiry to that which your particular audience traditionally is trained in and actually believes, a bit religious, you know, sort of believes. So it's a really big challenge, I think, Andrew.
So can I follow on just with another comment? Is that all right? Because I think this is the issue, that actually to advance the field, actually the status quo makes it very difficult to publish on these topics. We've certainly struggled in the same way that, you know, when we try to integrate personality disorder into the staging model, people describe reviewers describe the papers as curious, or you know, and so you get these reviews that come back that, you know, that embed the status quo. The whole system of publishing really it makes it very difficult to advance this field, I think, because each silo is invested in the Journal of Affective Disorders or the, you know, Schizophrenia Bulletin or whatever it might be. And I just wonder what thoughts you have or suggestions you have about how to advance the field, apart from publishing everything in early intervention and psychiatry.
If I may make a comment, I think publishing is obviously it's one area, but in terms of actual service delivery, I think this is going to be a very complex and dynamic process over a long period of time, because looking at it from the other end, you know, if you have developed expertise in treating disorders that go beyond 1B, you're not going to be able to integrate all of that into primary care. So you still have to have pockets of high level of skills to deliver that care. I think at some point it will probably take us years to make some adjustments around that most of this should be really based in the primary care, in a different kind of primary care, not the kind of primary care we have right now. And then that to be backed up by expertise, not necessarily has to be in diagnosis, but in terms of actual interventions that are not all going to be provided in primary care.
Yeah, it's a great point actually, but I suppose the key really is in the title of the conference is the International Early Psychosis Association. I mean, and I suppose Ashok has written a very nice review, I suppose pointing out the kind of, I haven't quite figured out why, but it seems that psychosis of all the disorders has been the one to embrace this idea of prevention. And I mean, mental health in general has ignored the idea of prevention, but for some reason psychosis researchers were the first to move in, I suppose, with led by Alison and Pat and those, to this looking at the early, and Jan is one of the few really affective disorder. I mean, it's not big in affective disorders, this idea.
No, we get thrown out of the conference more regularly. Yeah.
Oh yeah. But and so I think that's why there's a lot of psychosis in this meeting. But and the other thing is there's an interesting field of youth mental health which is emerging. I don't know if you're involved in it, but I know. So are any people here in the audience involved in the youth mental health? Yeah, there's a few. Alison, yeah, you talked at our youth mental health conference in Dublin or Cork recently. So that's beginning to merge, and it's really interesting because a lot of psychosis researchers like myself, I suppose, are now getting interested in this, and Pat, of course, leading this youth mental health model. So and I suppose the problem with youth mental health is, and I've been to a couple of the conferences, there's no science, right? So it's a bit kind of frustrating, you know, when it's really nice and it's wonderful and it's very idealistic, but there's no science. You come to a psychosis meeting, it's like, oh, it's all science, it's wonderful. So we need to merge the two, and I think the psychosis researchers in general are the ones who are trying to maybe, and Ian, that's why it's great what Ian's doing, is applying the science to the youth mental health. Yeah, so thanks.
Alison.
Thanks to all three speakers and to Andrew Channon for very interesting questions as well. I guess one of the tensions that we face is between early intervention to try to prevent poor outcomes versus the Norman Sartorius sort of example where we risk stigmatising people very early on and pathologizing people early on, and that is a real tension that we face. And I think actually what you said, Mary, is the way forward, what all people are talking about, which is really looking at youth mental health so that people can get treatment in a non-stigmatising environment. But I just have a kind of a controversial question, I guess, for Ian.
I'm going to argue with Alison for a year. Let's go. We're going to be very Australian now.
You know, to what extent do you think some people might be getting worse because they're getting treatment that doesn't suit them? And there was a study actually by Shone Lewis's group. I can't remember what acronym it went under, but it showed in a secondary analysis that if the therapeutic alliance was good, then it didn't matter what sort of psychological treatment people were getting, they improved. But if the therapeutic alliance was poor, and this was measured by that California CalPAS thing, if the therapeutic alliance was poor, people actually got worse with psychological treatment. So I wonder if that's something also we need to think about.
Yeah, I mean, you know, as a psychiatrist, spend a lot of my time in the public domain. Most days will be defending it in the public that actually we do more good than harm. Most people assume we do harm all the time. You know, and I think it's a serious question for any of our clinical services. To what extent do they exacerbate the problem, either directly through the intervention or indirectly through things like stigma or isolation? I think this is the key issue, the one you've alluded to, and you've expressed the reservations kind of elsewhere. You know, who do we bring into treatment? And I think it's where the 1B thing's really important, because that thing is in a sense defined in part by function, right? These are kids who are already actually functionally impaired. Now, one of the interesting things is, have they always, and if you take the classic paediatric growth chart, have they always been off the chart? So I think what we need to add to that is a real sense of trajectory. Where have they been? I think the answer around the diagnostic thing, to go slightly different, is that the papers we're really interested in, that we actually only ever publish in open access journals because they're the ones who ever take them, are actually around clustering issues. What are actually the key issues that are going on in the particular? And one is, kids who have been dysfunctional, like a low level of functioning continuously with neurodevelopmental problems, etc., and they arrive in the services already functionally impaired, and is the service helping or making any particular difference, or are we actually providing the wrong intervention? So I would say in those groups, I think we're probably providing the wrong intervention all the time. They don't respond to psychology light, and they may be made worse by it. We've tried to take a number of those kids with sort of more autistic spectrum things in certain group therapies around socialisation. They hate them. They hate them. And they're also groups that often get over-medicated in particular ways. So I think it's a serious issue. I think the thing about the transition thing, they're people who are changing. They're not necessarily people who just aren't improving. So to pick up an earlier point about Ashik, which he said, but this specialisation, I think the specialisation is going to be in the management of emotional regulation. The specialisation is going to be in the management of social cognition. The specialisation is going to be in the sort of vocational interventions. Right? The specialisation we're going to have in the future isn't whether you're a schizophreniologist or a bipolarist or something. It's going to be in, do you have the skill set for the really important things that are the latent variables, the underlying things that are driving these sets of problems that we are seeing, which are then presenting for care.
And I guess we've got to be able to identify those particular needs.
Yeah, so I think that's the real issue, is what are those key things, those key real pathophysiological elements. And I'm not a believer, sorry for the English in the room, I'm not a believer in primary care at all. I'm actually a believer in the specialised delivery of the right care at the right time. And but how do you do that at scale? How do you not just do that for a few people, but how do you do it at scale? And I don't think it's by generic primary care models at all.
If I can just add one of my own concerns to this staging model, is that we're still concentrating on psychopathology and symptoms to a large extent. And the outcomes are likely driven, and that's why some people may be getting worse with treatment or not getting better, are also determined by social determinants, material deprivation, social deprivation. We really haven't got ourselves yet organized enough in our thinking to incorporate those elements as well when we present some kind of a prognostic trajectory for individuals, irrespective of diagnosis. And we know that those are actually some of the main determinants of outcome, whether you look at schizophrenia, you look at bipolar disorder. So I'm going to open it up for some other questions.
I still have the microphone, so can I just make a quick comment? Just to agree with you.
As you are the pioneer in the field, we'll give it to you.
Just to agree with you on that latter point. So we just published a study recently that found childhood trauma, regardless of transition or diagnosis or whatever, was a predictor of poor outcome.
Can I just get in on Alison's point there? And also something that Ian mentioned. I mean, my worry about the psychology interventions, Ian, is psychology is often packaged in terms of 6 sessions of CBT or 12 sessions of CBT. And I know in Ireland, the Youth Mental Health Service is very much in terms of, 6 sessions and you're out. You get, but I really agree with your point. Some kids need long-term, low-level support. And I think that's something we need to factor in, and my worry is that psychology doesn't think that way either. I mean, they have their own way of, just it's X sessions and you're finished.
I've got the microphone again. So it's just going to be Alison and myself, I think. Sorry, Mary. I wanted to disagree with your comments, because actually I don't think that the psychosis field has the lock on the science in this area. The problem I was alluding to is that the different fields don't talk to one another, and that actually, if you look at the work that's been done on the structure of psychopathology, there's an enormous amount known about latent vulnerability factors, and particularly, I think, one of the most important papers was Caspi's work on the P factor, that essentially there's one underlying factor for people developing psychopathology. And so there is a lot known about the structure of psychopathology, its longitudinal course, but we don't talk to one another about that. And I think we still look at it from our own narrower perspectives. And so I guess what I was really advocating for is at a clinical service delivery as well as at a research level, that we do broaden our approach rather than look at what we're more comfortable with looking at.
Yeah, that's true. And that's really interesting, actually, the P factor idea. And I wonder how that links with the clinical staging models. I was thinking that during Ian's talk, how are we going to marry these two together? But interesting, like Avsham Kass, yeah, he's done work on psychosis as well. You know, so people can pick and choose and be eclectic about it. But I suppose, yeah, I was speaking very much from my own bias, I suppose, coming from psychosis. But the P, yeah, that's really interesting. The P factor model. I think we should be looking a lot more closely at that.
So, I mean, we do assume, and I think this is the way psychiatric genetics has gone, I think it's the way the imaging is, there's a big general factor. That big general factor is expressed during the adolescent period, no matter what its other precursors are. And then there are various other variations that play out that affect the individual course, many of them in the psychosocial domain, complicated by other issues like drug exposure or prior sexual abuse, whatever, in particular things. I was going to say, just sitting in front of Andrew's Murray Wright, you know, who has one of these terrible jobs of actually being responsible for a state health system. You know, if you're looking at this, Murray, from a state point of view, I mean, do you care what diagnosis they got? You know, the need for care and the service providers who have to manage these kind of systems. I mean, our diagnostic, there's something, I think we're lost on one of those magical medical myths. If we could just get to the specific diagnostic bit, we'd have these magic breakthroughs in each particular area. And then we could all justifiably have our own breast cancer clinic or our own, you know, other clinic and feel really good about what we did, when it's not really the nature of the beast that we're dealing with most of the time. So I think our history and our tradition, I don't think it's just that people don't talk. People don't want to give up what they got, in which they are well trained and well versed. And that's partly personal, it's partly on behalf of the groups that they look after. You know, they don't want to see them be worse off in the particular systems. But I think inevitably, I don't know if Murray want to comment, anyone who's having to deal with this at another level, you know, is well aware that nobody else cares about the diagnosis bit. It's the medical bit that really drives that preoccupation.
I think you're right, Ian. But in expanding the, and I'm going to talk like a bureaucrat for a moment, but in expanding the size of the population that we're trying to deliver a service to, which is what we're all talking about here, I am intrigued in your comments about the role of primary care and your substitute service for a primary care delivery, because I think that's one of the great challenges, certainly in our service environment, is that a lot of primary care has abdicated the field of mental health service delivery. And how do we do that for this generic population? Helps to destigmatise the service delivery, but it's also going to help to scale up a lot of the interventions that people are talking about. So can I ask you to expand on what your substitute is?
Yeah, I was a believer in primary care in the 1990s. I think wasted a decade of my life thinking if only we made the primary care system work better for mental health in general and then younger people within that. In fact, the primary care system is okay if you're a male about 50, if you're a woman about 30. Even then, though, if you go and look at the mental health problems in those groups in primary care, they're quite complex. They're not simple. They're actually quite complex, and they don't do the functional outcomes from those primary care interventions is not very good. They're well-established chronic disorders. So in fact, even those ones that are in that system, I don't think actually have very achieved. We spend money on the activity, but I don't think we feel good about that, but it doesn't achieve much in terms of outcome. All the work we did in the 1990s is the engagement of young people with those systems is about nil. And in fact, young people and old people got terrible care in those systems when they came, but the only ones who came essentially were young educated women into those systems. So there's a whole lot of other, what's costing society a more broader system, doesn't engage, and I would say isn't ever going to engage. I think it's where now technology, I do actually sort of convert for the technology kind of field. I think people can manage a whole lot of stuff in appropriate ways, better supervised, and I pick up Andrew's point, I actually think the great thing is getting specialisation to scale. You can put all sorts of things into those systems using specialisation to get those who need more sophisticated clinical interventions care, and they become the priorities in care rather than the classic thing that just the volume occupies the activity. So I think it's a really interesting phase we're at because they are the challenges, like scale and scale, but for what? Not just for more health activity, but for actually better outcomes. And I think that's where the early intervention thing still really matters. If you don't intervene early, your chance of getting a better functional outcome, I think, are much decreased.
I think we're over time, unless somebody has one final comment to make. I'd like to thank the other speakers, and thank you for listening and for participating. Thank you.